Hello, everyone, and thank you for tuning in. In this episode, Dr. Adelaide Hebert will share some highlights and clinical pearls regarding pediatric psoriasis. Dr. Hebert, thank you for being with us.
Thank you. I want to remind everyone in the audience that if you see a pediatric patient with sudden onset of psoriasis, think about a strep infection. I also teach my patients and parents to be aware that a strep infection can indeed be a key trigger in pediatric psoriasis. They should get quick assessment and proper treatment if that's the underlying cause of their psoriasis. It's important to look at the nails in pediatric psoriasis because the worse the nail involvement seems to correlate very closely with the severity of the psoriasis the child will have. We really want to think about all the aspects of comorbidities and children who suffer with pediatric psoriasis. And one other key thought is that if you look at the literature, we have an article that suggests that using a biologic agent actually leads to better clinical outcomes, better quality of life in the pediatric psoriasis population when compared to those patients treated with methotrexate. Keep in mind, too, if a patient has psoriatic arthritis during the childhood period, they should be seen by an ophthalmologist and evaluated for uveitis.
Thank you. Dr. Hebert, what is your personal approach to treating psoriasis in pediatric patients compared to other age groups?
Well, I certainly think about what is best for the patient and the parents in terms of management. In my very youngest patients, I have to admit, I still use tar, a very old-fashioned product, but it does work. It's not threatening. It's available over the counter. It can be used without concern about skin atrophy and so forth. I will combine that with topical steroids, depending on the severity and location of the affected areas. I do want to think about these patients in total. For older patients who suffer psoriasis who are eligible to go to one of the camps, I'm talking about the non-COVID era, I will actually fill out the form and recommend that they do attend a camp. It's very enriching for the child, and I think it helps them to understand their skin disease in the context of a greater society where many children do suffer with all kinds of skin conditions. I usually talk with the parents in depth to decide what aspects of care are most important to them. Is it the scalp that bothers them because the child itches? Is it the facial psoriasis that's most troublesome? And then we design a therapy that is really in alignment with that patient's lifestyle, the parent wishes, what the child can tolerate, and of course, what insurance will cover.
Can you highlight the different class of therapeutics currently indicated to treat pediatric patients with psoriasis?
Well, we have very limited therapeutic options that are FDA approved within the pediatric realm. In our very youngest patients, we have virtually no therapy. But as we get to about 6 years of age, we have biologic therapies. We have 3 biologics approved for patients 6 years of age and older. And these are excellent drugs that can really help the patients who suffer tremendously with psoriasis and even those who have psoriatic arthritis. So we're very happy to have those agents available to us. We only have 3 topical agents approved for patients in the youngest age groups. And 2 of these are actually combinations of calcipotriol and betamethasone. One is a lotion and one is a foam. And the other product is a calcipotriene agent as a solo ingredient. So again, our armamentarium for children is exceedingly limited when compared to the very many drugs that we have available for our adult patients. We do know that this is changing because as we submit in clinical trials to the FDA for approval, we often have to have a pediatric plan in place. So we hope as we go forward, we will have enough enrollment to allow our pediatric patients to have greater access to safe and effective medications.
Are there any considerations to be made when prescribing treatment for psoriasis in patients across the age spectrum, from infants to adolescents?
Certainly there are. In infants, we virtually have no therapies that are FDA approved, but that does not really limit us in our ability to manage their disease. Here we take greater caution because of the thinness of the skin, sometimes because of parental concerns, but also because it doesn't really bother the patient at that point, at least cosmetically or emotionally. However, we do take the disease seriously, and we convey that very carefully to the parents. As we get to the older children, particularly adolescents and teenagers, we have concerns about the psychosocial development of the child, the development of psoriatic arthritis, and the impact overall on the child's sense of well-being, their ego development. And of course, we know they're at risk for bullying and different problems as they approach school age. We address all of that. And again, design a regimen that's probably best for them. And as often as we can, we try to align it with the new guidelines published by the Journal of the American Academy of Dermatology, by the American Academy of Dermatology, and the National Psoriasis Foundation in January of 2020.
And final question, how do you educate patients and families to deal with the psychological aspects of psoriasis as well as the treatment adherence?
I think this is one of the greatest challenges we face when we deal with psoriasis. Just like any chronic disease, it's really hard for a child and a parent to accept that this may be a lifelong condition that they possibly have even inherited from the parents. So there's often a lot of guilt on the part of the parents that they might have indeed given this disease to their child. We counsel them about the psychosocial aspects. We counsel them about strep infections and the impact about future flares. We warn them about the use of systemic steroids, where it may get the disease under quick control, but result in a very apparent flare subsequent to withdrawal of those drugs. We also counsel them about other medications which are known to potentially cause flares of psoriasis. Drugs like lithium would be one example. We caution them about anything promising a cure at this point, although some of our biologic agents, at least in the adult realm, seem to be able to control the disease very comprehensively. We warn them not to expect a cure in the immediate future, but that to expect we are going to get better medications as we go forward that will help control their child's disease. We warn them about miracle treatments or treatments that promise rapid resolution without good evidence-based medicine to back that up. We unfortunately have a lot of patients who want to go natural, whereas very few things that are natural, save for perhaps sunlight, will really impact this disease in as favorable a way as we can affect with the medications available to us currently.
Thank you so much, Dr. Hebert, for sharing your insight with us today.
Thank you, Lindsay. Glad to be with you.
And thank you to all of our listeners. Until next time.